Associate Programs, Haryana, to please come here. We will start with the deliberations on the public-private partnership. May I request Dr. Kishore Phadke, pediatric nephrologist and convener Jiva Sarthakate, Karnataka, please come. We need more chairs here, Hemal. May I request Dr. Atul Mule, nephrologist and secretary ZTCC Pune, to please come here. Dr. Somnath Chattopadhyay, head of the department Hepatopancreato-Biliary Surgery and Liver Transplant, Kokilaben, Dhirubhai Ambani Hospital, Mumbai. May I request Mr. Amal Sivaji, Associate Director Healthcare, USISPF, to please come. Mr. Mahendra Kumar Rekhi, Managing Director and CEO of SBI Foundation. Mr. Aman Chowdhury, SBI Foundation. Dr. Sunil Shroff, Managing Trustee of Mohan Foundation. May I request Mr. Sandeep Kumar, the well-wisher of Mohan Foundation, I'd like to say that, a great friend and the well-wisher of Mohan Foundation, to please come here to participate in our public-private partnership session. I'd like to request Dr. Shroff to please take over.
A very good morning to all of you. And thank you, Lalita. So we have a number of very important people sitting here. We have an hour to do this. We've already spent almost an hour in different rooms, and we've discussed some of the problems to create a public-private partnership template. I think if you look at many programs in health, especially, the public-private partnership has been a success, especially in developing countries like ours. One of the projects which comes to my mind is eradication of polio, which was started by Rotary, and they did a lot to make polio go away from this world. Another project which comes to my mind in this field, as far as health is concerned, is the Smile Train program, where almost 500,000 cleft lip and cleft palate surgeries have been done, almost free of cost. And that was a huge project. And similarly, there are so many more. The Melinda Gates Foundation's projects on communicable diseases have been remarkable. And if you come into the organ donation field, if you look at blood donation and eye donation, we have 11 million blood donors every year taking care of the requirement for blood in this country. And most of these donations come from volunteers, and the push has been by NGOs. If you look at the eye donation program, every day there are more than 300 people in this country who pledge their eyes, who ring eye banks. And we have had last year almost 30,000 corneas being donated in this country. And again, Dr. Rajesh Chandwane, I forgot. Where is he? Rajesh, please. Please, sorry. When you have such a big panel, it's obvious that we are going to miss out one or two. But Rajesh is a friend. So Rajesh is a friend, he won't mind, I know. So I was saying that eye donation as well, if you look at the program, it's mostly volunteer driven and again driven by the NGOs. The organ donation ecosystem is very complex. And I think we have now, for the last 3-4 years, we have peaked. We've done from 700 to 900 donations in the last 3-4 years, and we don't seem to be going anywhere from here. The numbers are stuck. And I think we need to relook and see where we can take this program forward and what we can make different. And we already had discussion on this, on the PPP downstairs. I'm going to go through a very quick presentation, and then, I'm going to ask Mr. Davida to take over. The challenge of making sure that everybody is heard in this panel. And I'll promise you I won't take too long. I'll just be 5-7 minutes. Can I just open the slides? Where are they on this laptop? You're not connected? Okay, so where do I... It's wonderful to be in IIM Ahmedabad, a huge learning center. I hope all of you, the hall looks full. As Rajesh said this morning, it's unusual to see things, getting full so fast. Yes, Rajesh? So it's wonderful. I'm sure you all will enjoy the campus, and take some inspiration from here, go back and work harder in this program to make more organizations happen. Now the presentation, any choice? Any? Yes, I have it, but I just saw it somewhere.
No, this and that is not connected.
Which is not connected?
This
Because everyone is sitting here, you won't
Okay.
be able to show it here. We thought we'd
you
use
have to
that.
connect your pen drive.
What about other presentations? Have been done?
No, nothing has been done.
What about Mr. Davida's presentation?
Your presentation, Mr. Davida?
This is, sorry,
You already gave it?
we could save time if we, yeah. Where is this? Which side? Which side?
This is just for your reference. So you have to move here and with the pointer.
Sure. Yes.
But it's not connected. No, it's there, but Dr. Shroff only see.
Give me 1 second because everybody else is going to have the same issue otherwise. Do you need to get any other presentations here?
Everything.
Everything else is here?
No, nothing.
Rajesh also told that a lot of things will go wrong in this conference. Rajesh, you meant it, is it?
Technology helps everything.
But
Only it's not possible. We should expect technology to break down.
Yes, yeah, there we are. I'm going to do it very fast. I think I've lost some time. So, again, going through just to tell you, the GDP expenditure on health, this here, is it?
1 second. Just open.
Okay.
You'll have to move.
Okay, I'll do that. Okay, this is the main one. So the GDP expenditure on health as a percentage is about 4%, and 1/3 is from the from the public sector, and 2/3 is from the government. If you want, can you see? I know that this is going to be a little challenging for our people here on the dais, to look at. But you have a challenging task anyway, so that's fine. Please, please, please. The budget for defense last year was 4.5 lakh crores. For health, it was only 62,000 crores. Just goes to show the disparity of how much we spend. Currently, 13 of the 36 states and union territories do disease donation in India. Of these, only 5 or 6 do it regularly. India's disease donation rate is about 0.8 per million or 900 per year. The bulk of these figures come from these few states. Key organizations who have helped the cause and partnered with us in the public-private partnership. Sorry, I keep forgetting this. Some of the key partners have been Tata Trust, SBI, Times of India, NDTV, Edelweiss. If you look at Tata Trust support, they have helped us in conducting, for the last 10 years, training courses for grief counselors, transplant coordinators. We almost trained 2,400 transplant coordinators in various parts of the country through 1 week, 1 month program. We also do capacity building ICU workshops to train ICU people how to take care of brain death, how to maintain, how to identify brain death. We have done multiple workshops, thanks to again them. We also do training of surgeons along with Sonal Asthana, who is here, through Oxford. And we have trained surgeons from various parts of the country on how to do organ retrieval and how to do implantation of transplants. And these are some of the faculty who have come over various years, various programs. What I want to show in this is that some of the impact of this has been huge, and I think Sonal will tell you some of it when he talks. That, this is a gentleman who is from a, public care hospital in Madurai called Ratnavelu. He's a cardiac surgeon who had never seen a heart transplant. He came to this workshop, he did it for 2 days, went back and did 3 heart transplants. So these are the kind of impact you have when you do such partnership, And that got a lot of publicity, obviously, it was a good field kind of publicity in the media. We also work with organ sharing registries for Tamil Nadu, for Kerala, for Rajasthan. We have developed a software which works well, and we have been running this for the last 15 years. The SBI Foundation has been very kind to us in the last 2-3 years. They have helped us. We run a free phone, toll-free helpline through SBI Foundation, which works 24/7. And in 2018, we handled 12,000 calls through this SBI Foundation helpline in 8 languages. And Hemal is the key on this, and she is here as well, and she will talk about her experience with this helpline. And the key in this helpline is we only started this helpline just to give information on organ donation, but we have started doing organ donation through this helpline. We never expected this outcome from this helpline. And that was amazing even for a person like me who has been in this ecosystem for so long. And over the years, over just last 1 year, we've done 31 solid donations where we have had calls from as far as Dubai where they have said, my loved one is here, he may be, doctors are saying he's critically ill, his brain is gone, what do we do? And people have counseled from here for 1 hour on the helpline, and they have gone on to do organ donation. So we did 31 solid donations, 6 corneas, 1 bone donation just in 1 year. And besides that, we've done many corneal donations. Regularly we're now doing it, corneal donation. The Times of India print campaign has been a great success since 2000. I think 13 we started the Times of India campaign, and through this about 1.72 lakh pledges have come online, and they do it every year in the first week of August, and they make it an organ donation week. And then we have had Edelweiss recently who have come on board, and they did this Guinness Book record, and they got about 1.32 lakh pledges just over 24 hours, and they made a video with Rahul Bose. So these are some of the success stories with this kind of partnership. NDTV again has done many campaigns and have had pledges. This again is through Fortis, and we have again associated with them. And these are some of the campaigns which really helped in this public-private partnership. We've had public-private partnership with many governments, including Tamil Nadu, Kerala, Rajasthan, Telangana, and now also with Manipur. Some of the partnerships have been a great success. Some of our partners are still evolving, just like the Manipur one. In Odisha, we didn't succeed. In Tamil Nadu, just to tell you briefly, we do counseling services. We provide coordination on the ground in the government hospitals, in all hospitals in Tamil Nadu now. And if you look at very briefly the success of this, 310 certified brain deaths over 6 years, 302 families approached for organ donation, 98 said no, but 204 said yes for donation. And this resulted in 148 multi-organ donors, 67% conversion, just amazing. And number of organs, 518 organs and 937 tissues. Telangana, similar story, 3 hospitals, similar kind of successes. Maharashtra just started about a year back, in 2 hospitals, 14 brain deaths certified, 14 families approached, 9 organs said no, 5 said yes, 5 donations, 36% conversion rate. This is from 2 hospitals. Again, multiple organs. Rajasthan started again, 5 years back, and again 93 families certified, 88 families approached, 59 donations, no, 29 yes, and then again multiple, 49% conversion rate. And again, many organs. What I'm trying to say is, if you ask, if a certified, trained transplant coordinator and an ICU consultant work together in the program, at least 3 to 4 families out of 10 will say yes to donation, whatever may be their background. And this you need to believe. The problem today is this program is not in the public domain. It is in the hospital domain. And we need to create certain public-private partnerships to take this drive this program forward. Various NGOs in this program who have helped, and some of them are here. Nilesh is here from Surat, and Jubilee Foundation from Assam, and so many others are here. Organ India is here somewhere, sitting in the audience, I'm sure. They've all done commendable work, donate life, and so on. Commendable work in this program. And 95% of all awareness are being done by these NGOs in this country. And all these efforts put together has culminated in the disease donation numbers from if you look at 2012, we had done 196 donations. If you look at 2018, we had done close to 900 donations, almost 4.5 times in 6 years. And this is culmination of all the work done by various NGOs, various government, various private hospitals. We have been able to do that. But PPP is a challenge. There are lack of systems in the hospital, no brain death audits takes place. Lack of support staff in the hospital, no systems in ICU for maintenance of brain death or identification of brain death, lack of resources for the program, lack of ventilators to maintain brain deaths, lack of dedicated staff for the program, liver and heart transplants, no infrastructure in government hospitals, lack of stability at the top. The changes happening in the administration, the head secretaries change, the DG change, the dean changes in government, so the whole system changes at times. Lack of support for systems in non-transplant organ retrieval centers, nobody bothers to talk about that, and there's a huge potential there. So there's no state level policy on NTORCs. And then there's some lack of trust, because sometimes working with NGOs, some of the governments are challenged. They don't trust the NGOs. So in first phase, we feel that currently we have 550 transplant units in about 300 hospitals in the country. There are 260 government medical colleges of the 532 medical colleges we have, and there are 9 aims. So we feel in the first phase, we could at least, put all these hospitals of the government as non-transplant organ retrieval centers in the first year, and second year subsequently they can become transplant centers for at least kidneys. If you do that, at least things can move forward. And these are the questions which we put for the PPP, and I'll ask Mr. Davidar IS, who has been the architect of the Tamil Nadu program, to take over from here, and then the deliberations. Yes, sir. You want to change the diagram?
No. Yeah, I'll.
Or you want to put the pen drive? Yes.
Yeah. No. After 2 weeks. Friends, I think this is how it's going to work. We had 3 groups which sat in 3 separate rooms, and we discussed, and we have some kind of a consensus on what the the focal points are. What we are trying to do in this 1 hour session is actually extremely ambitious. What we are trying to do is develop some kind of a template, and more than the word public-private partnership, I would say to grow diseased organ donation in India. And although we are looking at brilliant success figures from where we got started about 10 years ago, we are actually looking at just about 6 states. Am I right, Dr. Shroff? We're just looking at about 6 states that have got started, and a lot of the 6 states are actually at a kind of a plateau. The states which are looking good today are the ones which are looking with no progress and looking at hope in terms of moving forward. So it is in this context that we are trying to look at what kind of a template should we have. So what we would do is we would have each of the group who are represent. I think one of you is going to do the presentation. So they would, each one of them will do it for about how many minutes? 5 minutes. Okay, Dr. Shroff decides. So that's again going to be a difficult thing. So we are trusting our scribes to deliver and pick up all the valuable points. After the presentations are done, I have a few slides again for another 5 minutes. And then we would open up the floor for discussion where we brainstorm, and we have to cap this whole session at 11:30. Uh-huh. Dr. Shroff decides. It's 11:45. Thank you, Dr. Shroff. I agree with you. I agree with you. So, shall we get started, please? The first group, I'll ask Dr. Suresh to.
No, I think you give me enough time to prepare. Do I plug it in here? Huh? Go ahead. It's IMA today's date. Come there. Huh? I have no problems. Put it wherever. I have no. Can I control from here? Yeah, no. We just only just 3 slides. Just the key points for the. So, just as they set this up, I'm Dr. Suresh Shankar. I'm a nephrologist from Chennai. Our group had Dr. Kishore Fatke, who's the convener for Jeevan Sarthakate at Bangalore. Dr. Atul Mule, who's convener for ZCCC from Pune. Dr. Dhiren Shah, who's heart transplant surgeon at SIMS Hospital, Ahmedabad. And Pallavi from Mohan Foundation. So the six of us had 3 key questions. One was how to encourage organ transplants in hospitals around training, awareness, and brain death certification. That was one question. I am in today's date. So that was one. Yeah. That's one. Yeah. So put the next slide here. Can I control the slides from here or? Okay. So.
No, you can't use it here.
Okay. I can do it. This. Okay, fine. Yeah, I can do it. No problems. So the first question was how do you encourage organ transplants in a hospital and with regards to training, awareness, brain death identification, and what are the training needs? So just as STEM points which I have displayed on the slide, one thing was from the Gujarat side, we heard that they're exploring the option of an organ donor coordinator covering a zone covering several hospitals. So as against the transplant coordinator, as it is restricted to a single hospital kind of an approach. ZCCC Pune has quite an active process in motion with regards to involving the hospital intensivists and neurologists as part of the NGO working framework itself, with regards to they being part of the NGO's meetings, the advisory board, part of their guidelines preparation for the region, deep into how the NGO's ZCCC operates itself. So it's a more dynamic relationship between private hospital and the non-profit. I, for one, believe that as you're entering into hospitals to look at donation, there's always a rippling effect of how that gets perceived by hospital staff and also patients, because there's always a lot of crosstalk. So I think in addition to intensive care, I think there needs to be a broader hospital messaging, something like, when you see infection control, it's a very broad messaging inside hospitals. You need to take an approach like that. From Dr. Fatke, he felt the government participation is very critical in the early phase of the program to build credibility. And one of the things that they have done in Karnataka is to, as they see slowness from the public side, they've partnered with NIMHANS, which is a very credible organization regionally. So there is an impetus to that. The incentive seems to be a very burning question. I guess we'll take it up on the discussion. And the other point was the organ helpline, which was a need from Gujarat. The next issue is about quality of transplants or hospitals. The question is centered around how to monitor quality of licensed transplant hospital with an improve to oversee donations and look at the key elements. Questions like whether the brain death declaration is done routinely, what is the conversion rate, and issues about what does the families perceive and what is happening to outcomes. Here there was a clear consensus among the group that I guess we'll have to start talking to NABH. I think for those of you who are involved with NABH in hospital where you work, NABH has a lot of structural elements with regards to objectives and standards. Somewhere in that, if it's a transplant hospital, when they come for accreditation or for renewal, this element with regards to oversight of transplant needs to be brought in. And JCI, which Dr. Dhiren Shah mentioned, already has a process when they come for accreditation. So NABH is built on international models. So I guess NABH, from other interactions I know, is open to input from the industry. So I think there is a scope there to push the dialogue. The other issue with regards to brain death donation is also the legal clarity post donation, which hospital seems to have a huge challenge. On the outcome tracking to see what happens to post donation, which brings again transparency and also the proof of the pudding as to what happens to donations in that region. In Tamil Nadu, I'm sure Dr. Shroff will want to add more, but I being a small part there, I know we've not had the best of outcomes with regards to the collective reports of what happens to all the outcomes. But ZCCC mentions that survival of patients are at least reported on a periodic manner collectively to the state appropriate authority, but there is not the next step of the analysis to see what can be done about it. And I think the big experience, which I think is very key personally, is what is the actual experience of the families itself as they go through the donation, because ultimately all the top end is about on the provider side. All of this is on the provider side. I think this needs to be looked at, what the families. I guess the best way to actually is, with what Shroff mentioned with regards to the grants, to actually take this as a survey, as a structured study for multi-site to see what they are doing. And the Surat model was quoted as being something that operates from counseling to cremation, which is a very comprehensive approach. So maybe if we incorporate a survey, including Surat and a few other centers, we'll bring out a wealth of information. And the last bit was the NTORCs with regards to non-transplant organ retrieval centers. Clearly, the issue of a hospital committee is a heavy load on the shoulder of small hospitals to do that, and the suggestion for having a public committee to oversee was would be impractical. But the NTORCs clearly have the challenge of knowing what happens post donation, of knowing what will happen to the cost and the outcome to the donation. So that creates a lot of hindrances for them to get into that space. What I quoted was how in healthcare, speaking of cross-learning, how hub and spoke models work. There's a very good, effective running model in Tamil Nadu, I know, for myocardial infarction care, where tertiary care hospitals are linked to smaller hospitals, and the entire network works in rapid speed from the point when patient comes into a smaller hospital with regards to the plan of care assessment and everything. The same operates for ethics committees, for research protocols in smaller hospitals when they're teamed up with larger hospitals for oversight. So in some way, but again structuring this, if the local policy structure and also NGOs can handhold to seeing which hospital can be paired with which. There was a suggestion about the pairing happening within the sector itself, meaning within private or public. So that way the smaller hospital has like a big brother. There are sister center programs in nephrology where there is somebody they go to as against just being out left in the dark. I think that is something that can be explored. So these are the broad things. Dr. Shroff, I've stayed within the 6-minute control. Thank you. So I've left it as STEM questions, STEM, so we can always take up deeper discussions.
Thank you, Dr. Suresh. That was slick. Thank you very much. Now we will have the second group, Dr. Rajesh Chandwani, to give us the feedback on what they came up with.
So good morning. As discussed, the 1 hour period to have a comprehensive discussions on these broader questions which are encompassing several system level issues will be tough, but we will try to highlight what came out in this 5 minutes. In 5 minutes, what the discussion went about. The first was to identify the scope of private sector hospitals to participate in the care of less affording patients. Can trust deficit between government and private be bridged through some initiatives, where an example was shared where in Chennai some private hospitals are tying up with the government hospitals and the doctors come and do transplant surgeries in the government hospitals. So this was discussed. The interesting thing was when we talked about these initiatives at a policy level, the first point which was raised was does the law because the organ transplant law is very stringent, and it needs to be stringent when the law is evolving and the country is experiencing these type of multiple stakeholders working in this domain. First is to have a clarity about what is the legal arrangement about these partnership. The second point which was discussed was there is a seemingly dearth of resources, human as well as infrastructure resources in public sector, but if you see pockets of certain public hospitals, these are not an issue. So it was said that maybe it is a champion driven thing if the top level of a hospital or the government hospital or the government organizations in that state, if they are taking an initiative, then maybe it is not a state level or a country level issue, but it is a specific hospital level issue. And that is where we thought that it would be important to highlight, say, select 30 or odd hospitals across the nation, maybe based on some metrics which we thought which we will evolve in further discussions on when they are having a successful partnership with private organizations, which might be sharing of human resources, which we thought that it is not difficult, as most of the doctors who are working in private come from government medical colleges, and it would be easy for them to initiate that giving back type of thing to work with the government hospital. It won't be difficult, but these three things have to be in place. One is the clarity on the rules aspect. The second thing is the human and the infrastructure challenge to be met when the organization has a top level support, and then the initiative which is like twinning partnership, or we also discussed some of the models based on Gujarat, where the public-private partnership exists in, say, a kidney transplant, where even public hospitals are doing good work in those areas. So we thought that these different models can learn from each other. That's how the thing should be processed. The second question was about point number 5. Role of NGOs. So what should be the role of NGOs? Should it be defined clearly, or how the NGOs and the government partnership can take it forward? So when we designed this workshop on public-private partnership, it was not restricted to private for-profit corporate hospitals. In the private, we included the civil society and the NGOs also. So interestingly, what we discussed was each of these three organizations, whether it is public, private or NGOs, they have their own niche strengths. For example, government organizations, including the public hospitals as well as the government, has a systems view. They can see the interconnect between various subsystems working in the whole public service delivery. The private hospitals, on the other hand, focus on efficiency and focused approach. The NGOs have the strength of connect with the community. I think leveraging these three strengths should be there in the partnership whole process. For the NGOs, what we discussed was, one of the important thing which came up was the role of NGOs in grief counseling, because when it comes to a government hospital, can we place a person who is trained in grief counseling from an NGO? Because many of the NGO, the people who work in NGO are driven by passion. That's what the theory says. So if we can draw from that, and we can have a partnership where specific role of, say, grief counseling can be shared with an NGO within even a public hospital, that was discussed. A point which was raised on OPOs, the organ procurement organizations, can that, because in the Western society NGOs are interested with that role. My personal feeling, but it was not discussed because of lack of time in detail, was OPO being led by an NGO would be a great leap of faith here, because many of the NGOs may not have that credibility in the society as of now, but it may evolve. But I think monitoring and evaluation like one system which Dr. Shroff was highlighting, which has been made for Kerala, Tamil Nadu and one more state, where you have made a system but it's owned by the government. So I think for the credibility issue as of now, OPOs may not be the right task for the NGOs to be performed, but yes, grief counseling, monitoring, evaluation, awareness campaigning, all those things. In awareness campaigning, it was said that NGOs should not spend money, government should spend money, NGOs should contribute their know-how. The last 2 points were regarding the funding. Funding organizations like SBR Foundation work with different NGOs and bring to table their expertise. How can we leverage on their network? And the related question was, how can industry help in organizing or augmenting organ donation? So here it was discussed that both of these stakeholders who provide the financial support and also have the overview of various NGOs working. One of the ways in which they can contribute is, can these learning be discussed when, because they have the overview of various, say they would be funding in Manipur, they would be funding in Jharkhand and as well as Gujarat. So learning from different states, because these are contextual issues. For example, in some state like Tamil Nadu, awareness might not be the focus, but in some state like Rajasthan or Jharkhand, awareness might be the focus. So how the learning can be collaborated, the collaboration can be based on the learning which can be transferred from one NGO to other. The second aspect was learning from the industry which has successful implementation models in, say, other diseases. The thalassemia model, hemophilia model was discussed, where industry has in a purpose or a sense of direction towards elevating that problem. So we can learn from that. That's what was discussed. Any points which are remaining, we will take it up in discussion. Thank you so much.
Thank you, Dr. Rajesh. Now I request Rakesh. No, you will start and then I come. Dr. Rakesh Gupta.
So, 6 states are doing good, as we all know, and there are other states who have not started. So Haryana is one of them. So I represent Haryana. So Dr. Rajesh very smartly, he invited me, because if you come all the way from Chandigarh to Ahmedabad, you are going to commit something. And yes, we are committing ourselves. So my Chief Minister, he is more than happy to commit to the cause of organ donation and transplantation. Can I see? Pointer? Yeah. So I'm just going to present 2-3 slides just to sort of commit and how exactly we are going to do, and rest will be taken up by my colleague. So this is the threefold strategy. So we know what are the problems, why we are not able to click across the country. So we all know the challenges. The solution design for Haryana based on our successful implementation of high impact programs in Haryana. So this is threefold. One is about the SPCC campaign. Second is about setting up of transplantation retrieval centers. Third one is how do we have a robust review and monitoring system in which we converse with various stakeholders. So first is there are many people who are going to talk about the awareness strategy. So I'm going to take only 2-3 slides. This is regarding setting up of the identification of government and private hospitals with ICU facilities where this can be done. Right now we are doing bare minimum, actually nothing. Second is how do we monitor, appoint and do the capacity building for the transport coordinators on say potential 20 hospitals across the state, which would be from private sector and government medical colleges, etc. Third is how do we ensure that the brainstem death certification is done across eligible hospitals. And fourth is relating to retrieval of eyes from deceased, which is relatively easier. So the third part of strategy is how do we ensure that we have a robust review and monitoring system. So here, based on our successes in high impact programs in Haryana, one of them is Saving the Girl Child. We would have all heard about the Beti Bachao Beti Padhao program in Haryana. Haryana was known for killing the girls, but of course it has been a major international story. So based on that experience, we are presenting a template here. So the first circle is the Chief Minister himself, his office and his Good Governance Associates. These are the Chief Minister's Good Governance Associates who actually work with Chief Minister and the Chief Minister's office, and plus they work very closely with their respective district collectors. Second is the district magistrate, which is very, very important. Like in other programs, what we propose here is that the district magistrate, district collectors at the district level, they take the lead. And of course, all other stakeholders, including the police, the health department, they are all important stakeholders. Third, very, very important, the civil societies, NGOs and foundations, and of course, because of Dr. Rajesh's invitation, we are coming here, and of course we are able to talk to the people who can really support us, and there is no need to reinvent the wheel. Lots of works have been done in various fields, like we have seen so far and in the rest of the conference. With me is Dr. GL Singhal here. Dr. Singhal, can you stand up? And he works 12 hours a day on Beti Bachao things. So can we have a big round of applause for him? He has been working after retirement. He is very young. After retirement, he has been working for the last 4.5 years, works full time. I spend hardly 10 minutes every day. So he is going to stay here till tomorrow, till the workshop completes. So if we can talk to various stakeholders, that is definitely going to shape up our program in Haryana. So we really look forward to various partnerships, including the Mohan Foundation. Next one is various hospitals, government and private hospital, medical colleges, and then various NOTO, ROTO, SOTO, all these, and the various other departments. So all these stakeholders, we sort of come together, rigorous review structure, and this is one slide which is perhaps very important slide, our learning from various successful projects about which I am going to talk in the afternoon. These are the Chief Minister's Good Governance Associate Programs. And these youngsters, whose average age is only 24. So I believe that this institution can really help in driving this particular program also. So what these associates can do is, they can support their respective deputy commissioner or the district collectors by setting up data-based reviews by the district collectors. It's very important. District magistrates in India are called worthy district magistrates, but most of the time they know nothing. So they are reviewing various programs right from the beginning till late in the evening, but at times they are not given the correct picture. So the departments, the various departments, they don't give the correct picture. So it's important that they really understand what they are reviewing, what is the relevant data. So these youngsters, associates, they help the district magistrate. Second is that these youngsters, they do the ideation. They learn from here and there, from the state, outside the state, maybe from outside the country also. And then they sort of drive the organ donation part also. All these stakeholders, they bind all of them. And third one is, they actually give the authentic feedback to the district administration and then to the Chief Minister also. And what we believe is in the entire impact cycle. So impact cycle is basically, we identify the problem, diagnose it, and this could be different from state to state or district to district. And then actually quickly pilot and then scale it up and then do rigorous monitoring. So these are the, I think, part of the strategy which Haryana is going to adopt, and finally the commitment which the state government of Haryana, we are really committing to this cause, and in one single year, Haryana can save almost 10,000 lives if we do this properly. Thank you so much.
Friends, I've just put a few slides together, and this is trying to collate a whole lot of thinking which has been going on for not just now, but for a long time over several conferences. And I put some of these slides down in the hope that in this process, actually Dr. Shroff's dream is that in a short while we will come up with a template, write a white paper, so that any state, if it's not yet started, will get a pretty good jump start by just virtue of the documentation in terms of how to go, and B, if a state has got hit by the Plateau syndrome where you are just leveling off with no growth, you could actually see where you are going wrong or where you are going slow. So he's got a very ambitious concept, and he's been pushing me very hard on this. So I think let's just quickly, I'll be really fast. The first thing is, I think legal, already mentioned. One is the knowledge of the legalities, but bigger problem, the perception of what is legal. We are looking at the law, we are looking at rules, we are looking at government orders. And from our experience and those of many states, the lack of government orders can seriously hinder the gray areas of the rules and the law. Secondly, it can, good government orders can facilitate and increase the comfort level of all stakeholders in the organ transplant, particularly in disease donation. 2, stakeholders. The most difficult thing about organ donation is that it's unlike any other specialization in, not just in the health sector, in any other department. Too many stakeholders. We have to factor them in, otherwise, it's not going to work. First stakeholder, biggest stakeholder, donor, his near relative and immediate family. Again, already mentioned, government may not be very good at recruiting the right people for the right job. NGOs may be better off, but NGOs need support. How does that work? We need to bring that into the template. Then caregivers at the hospital, we're talking about those who have been providing care for the person who's going to be declared brain death, and that's a big psychological obstacle to overcome. And so we're talking about the whole department where that individual is a big stakeholder, very big stakeholder in this whole process. The transplant coordinator, you're all here motivated, fully trained, so you're not a problem, but you're helping to solve the problem and you are indeed a big stakeholder. Then the brain death declaration team, and there again it is a big obstacle because you have to have so many people coordinating, coming, going, declaring brain death, and without them a harvest cannot take place. Then the police, because RTA is our single biggest organ donor. Transtand is our body here, and many of us have got different bodies like ZTCC and so on, and they can also be a problem as well. Then the logistics team to transplant the organs, okay, and then of course the transplant team. Now, the stakeholders, typically if you classify them, they are government centric, they are hospital centric, and they are region centric. So we have to really pin down the stakeholders in all these three and see how they should work together. I think the new states, or rather the states which have not taken on, are better off if they are, spared the learning curve that all of us went through. I think there's been a huge learning curve for states that have gone through it. Then, of course, state-centric, like I mentioned, every state. Like if you have the chief minister backing your program, you're already home. Or you have the health minister backing your program, you're home. If you have the health secretary backing your program, you're home. But if you have none of this backing you, you're not home. Committees. And then we have the committees. The heart and lung committee, and then you have the kidney committee, then you have the liver committee. I'm sorry for not being very polished about it, but then these are the main organs, and typically across hospitals everybody is an expert. So you need those experts and their buy-in to avoid controversies, and for them to understand there is a system in place. Many times if any one specialist in some hospital is eager to do more transplants than everybody else, you can have problems. Then you have the general consultation and advisory committee, and then there is the coordinating body. The advisory committee is more about expression of issues that are cropping up every now and then, and the coordinating body is a little more about authority. So the coordinating body actually has authority. So these are two different things, but they pretty much add up to this. One is the composition and the other one is the rotation. Once in 6 months perhaps, or once in a year is too slow, but once in 6 months seems to be doable. Then frequency of meeting is what I mentioned. Donor availability, again, the registration process, the allocation process, and then about convergence. Convergence meaning, in some states, like in our state, we have one body sitting in, the authority sitting in one central location, and which is working out the allocations. And we are actually discussing the possibility of moving this entire function to the 108 call center, the emergency ambulance call center, because they are very good at protocols, they are very good at taking phone calls at any part of the day or night, and their process already on health related issues is seamless. So why have a separate office? Why can't there be convergence? So new states may want to work at that concept of convergence. And then of course IT, a very big player. There's one slide I've not put down separately, that's on transparency. If you don't have transparency in organ transplant, it will kill the program. I think I don't want to mention names of states, but there are states which have done extremely well and then which have been killed. But that's not because of transparency, it's because of other issues. But transparency is a big killer. If 2-3 hospitals feel that they are being shortchanged at any point of time, they're going to put a spanner in the works, and all the goodwill that you build up will get burnt in a single day. So transparency is big and a big stakeholder, and that's important, and IT plays a big role in transparency. Templates. We need a template. If you want to start a transplant unit, what do you need to have? You need a template for that separately, a sub-template. You need one for rankings. I think if in a conference like this, at some point of time, we actually meet and figure out that all this is good for a transplant ecosystem in a hospital, in a state, then we could come up with rankings about which hospitals have got it all right, which states have got it all right. So I'm putting this whole thing together, including if you have an advisory committee, give that a score. If the advisory committee is meeting regularly, once in 6 months, give it a score. So if we give a score, then we actually know where the rankings are. So there's a good consultation process. One of the key things that we found across states is, because of the number of stakeholders, if the number of consultations are not steady, then at some point of time they're going to hit a roadblock. So consultations really matter, and rankings will actually take it to the next level. Then we have a template for what is essential to brain death declaration, because at that one single point, too many people come together. Too many bodies come together. So a template for that. So we need growth. It's already mentioned here by the others. In medical college hospitals, we have several medical college hospitals who have got specializations and super specialities, but with no organ transplant program. That's a tragedy, isn't it? I mean, I'm still trying to figure out how you can have a hospital with specializations, medical college, tertiary care hospitals without transplant. Then ICU is doing brain death declaration. We have not made it as a matter of routine, but we need to bring that in. So how do we do that? And then secondary care government hospitals, which again have their ICUs. In Tamil Nadu alone, we have 220. So we are looking at a great possibility. Intensive training, we are already into this, so I won't mention that. Finally, most donors in government hospitals are from poor backgrounds. Most donors. And we don't have any system, and I think Dr. Suresh mentioned incentives, right? Incentive, everybody is suspicious. Are you going to give them money? Are you going to give them a job? Then if so, you're influencing them, and so on and so forth. But there is a desperate need for families which have been deprived of a loved one, typically those who are below, who are young and who are working, and the parents or the brother or the sister came forward to say yes. So definitely we need, and I don't know if any state has cracked this. I don't know of any state that has cracked this, but we need a system which will support and encourage or help in rehabilitation of donor families. And so recognition and reward. Now, I take full responsibility for this final statement, and the organizers are not responsible, not Dr. Shroff, not anybody else. Reward the donors, but don't reward the states. I think it's a disaster when you reward the states, because it sets off the most unhealthy rivalry in a very sensitive human program. And even today, I think there's a reward program going on in Delhi. Thank you very much. So I think we need to work towards this. I think we should have a function like what they're having in Delhi right now, but don't reward the states. Don't reward the states. Reward donors. Reward donors, reward individual donors, reward champions. And it may not be possible at Delhi. It is maybe possible at decentralized locations, state-wise or even region-wise. But I think, having been there from 2007-8, when we are now seeing that actually rewards can do more damage than good. It can send a false sense of ego into the whole thing. Then when ego translates into different realms, it definitely becomes political in our country. So let's just get rid of the rewards for states. Okay, so I'm hoping we start a movement today on that. So friends, I think I'm done on that. And now we open the floor out. We have still got 10 minutes. So if you have any suggestion on the template, on how what we can bring into a template.
Can we have Mrs. Jayanti ready? Then we can close and then these are the names actually, final names.
Okay. Okay, so which means we don't get anything from the audience.
We can.
Okay, we have 3 people who can give us one-line suggestions on the template. Anybody?
But did you want to tell anything about the media and your stakeholders? I didn't see that because I know it's from the chance.
Yes, the media was one thing we didn't bring into the template, but we need to bring it into the template. I think once we do deceased donor donation surgery, I don't think the patient should be highlighted and definitely not the donor as well. Now, there are problems in different states where the donor family tracks the patient down and then there's harassment that happens. And I think some of the transplant coordinators will testify to that. There is a problem in that. So I think hospitals have to sign on a strict no publicity policy on as far as organ donation is concerned. That should be a given. We've all been talking about it, but it should be a given. 3 people from the audience, please. Please.
Just a piece of advisory for someone who doesn't know about bureaucracy. Tamil Nadu has an excellent set of government orders. How difficult is it to translate those government orders, say, into Manipur? Is it possible to pick up those government orders and directly pass equivalents? Because that would save a great deal of time.
To pass them on to?
Another state.
I have not been asked one like this. You mean just lend them to a state or send them there for training or what?
No, the set of government orders, if they go from state A to state B, we're talking about developing, say, I would say Haryana.
Yeah.
So how difficult is it because it's already in one state in the Union of India. So is it translatable into another state?
I think it is. I mean, India is one country. For purpose of administration, we are just split into states. But otherwise, it is possible. There you are.
Dr. Phadke has to say something.
Yes,
I
please.
think this brings to the issue of political will. And that has been a big issue in, for example, in Karnataka state. And I'm sure it does like this in many states. That the government, unless that government apathy or inactiveness or whatever, they are not proactive. Nothing bureaucracy. That.
No, but my question was whether it's legally possible or not. Because whether it would.
No, unless.
They have to pass it separately directly. Yeah, yeah, and I've been talking to the government for an MOU for affordable transport for the last 6 months. I should have spoken to you first about who to talk to. Thank you for your talk.
No, I think this is a great idea. I've never had this being proposed at any forum, but let me take this on because that will be a head start. We have benefited in Tamil Nadu with the private sector. For example, Stanley Hospital in Chennai got Dr. Rela to come repeatedly, and then Dr. Rela's team who came and did liver transplant surgeries in the government hospital, and by that actually landed up training them. So we have a private to government working very well and it worked on the basis of an MOU. I don't see why something like that can't be interstate. Definitely. By a request, yes, please. Yes,
So this is worked in some other industries, but what you could do in order to get greater acceptance across different states is actually constitute an interstate, body of representative from various states to finalize a template, which is acceptable to every state. So that way you get an automatic buy-in of all the states. So you could do that with 8 states or 10 states or all 20 odd states.
I have one thing. See, right now, health has always been a state's purview, wherein the national authority cannot intervene in it. But I think this program of organ transplantation and donation should be a central program, and it has to be a unified program across the country. Because what happens in each state has its own issues, own problems, and then we are not able to duplicate the things.
Just one comment on that. We'll have it for another session. But I think we should also talk about the problems of having a NOTO which does not fully understand the point of view that you are speaking about. So I don't think we should have a centralized program, because today if 6 states have grown, is because 6 states have adopted and tweaked the model to suit their own situation and have been very successful on that. Where we are having a problem is when you have a centralized body saying this is how it should be done. So I don't know how we'll circumvent that, but I think this free flow of knowledge, information, specialization, experience should very much be there. Friends, I think I'm done on time. Okay. Yeah. Now she's going to be the last one on the block, and then I'm going to request Dr. Jayanti Ravi, another colleague of ours, to give the closing comments before we close this session. Yes, please.
Sorry, I just interrupted.
Yeah.
So I would like to know, when you're talking about PPP model, when you all are discussing, what about affordability and cost of transplants? Should we, okay, like just for the model, like should we consider that also? Because at the end of the day, it's the surgery which we are thinking of.
I think I leave that for that session, but the one possible way to get around it is to work on the transparency again, where every state publicizes what exactly a transplant surgery will cost on their own website. So then that levels off. It becomes a great leveler. We've been pushing for that for the last 8-9 years. We are hoping someday it becomes a reality. So I would like to just mention thanks to Dr. Rakesh Gupta, Dr. Kishore Fadke, Dr. Atul Malay, Dr. Dhiren Shah, Dr. Mahendra Kumar Rekhi, Mr. Aman Baya, Dr. Somnath Chattopadhyay, and Mr. Amal Sivaji, Dr. Shroff, Mr. Sandeep Kumar. Thank you. I'm sorry to have got the names wrong. Thank you very much for the time, but just hang on. I'm asking Dr. Jayanti Ravi to just come and give us closing remarks. Thank you very much.
I'd like to thank all the panelists and especially Dr. David Davidar for really giving us all an insight of how this should be done, how this could be done. In a way, answering the question that I think, was it Dr. Sonal, is that your name? You mentioned. I think that's how policy is formulated in most states. You know, as a secretary there, you'd look at the ecosystem, you look at what is Tamil Nadu doing, what are the good states doing, and then you take it, but you don't quite adopt it. It's not a cut and paste thing. Like you also look at when you do transplant. So we adapt it to suit our local contexts. And I think that's a wonderful thing because, and this forum, I think at the end of this, I'll be very happy if Rajesh ji and this team can actually provide these knowledge inputs because the contexts are somewhat different in different states. So you can't just apply that. But as everybody said, the political will is very important. And in our state, I want to acknowledge that we've had tremendous support from our health minister, our honorable chief minister and our entire team. Although there was some impasse earlier on, but now in the last about a few months and perhaps a few years, things have really geared up very well. And we've been doing pretty well, but even the incentive issues, there are a host of issues that came up today. And on the issue of awards to states, I beg to differ with Dr. David Davidar. Just as you have metrics to measure whether things are happening, we talked about a rubric to check whether the state advisory committees had, things like that could be measured to grade states. It's always an incentive to encourage the entire team, whether it's about the Beti Bachao initiative that Rakesh spoke about in Haryana, because I think somewhere all of us, and Indians in particular, when there is some kind of a competition, of course, we have to be very careful to make sure that the metrics are right, and it shouldn't lead to an unhealthy paradigm where you're fudging figures or doing so. It has to be very robust, good, sustainable, but I think that is also in order. And for me, this was a great takeaway too. The reason I sat on this side is I really wanted to be educated, and I appreciate the excellent work that people like the teams in Tamil Nadu have been hearing, and we've been looking at all the work that you've been doing, and we're also trying to catch up. And I think if you look at certain countries, just as a takeaway, the larger picture, as Dr. Shroff mentioned, we've shown it. India has repeatedly shown it, whether it was pulse polio. We've collectively, and this is absolutely not going to be possible if it is just the government alone. It has to be all of us coming together. There's a role that everybody has to play, whether it's the private sector, whether it is the civil society, and together, academia, everybody together, when we start working, when we respect each other, trust each other, and there is an ecosystem which allows all of us to contribute, it works wonderfully. A very recent example is also the Swachh Bharat mission. I mean, who could believe India was the open defecation capital of the world, as it was said, and then programs year after year for the last 60, 70 years, we've had toilets being built, but I think it also would lead to a lot of these, there would be open cemeteries of dead and defunct toilets, because the focus was not so much on getting an entire geographical unit as an open defecation free unit. Similarly here too, very roughly going by data, if we talk of, my numbers may be wrong, but what I understand is there are countries like Spain in the world where if you look at the per million population, the numbers that they're doing, if I compare it to our state, they're nearly about 40 times, which means, and in our country, I think this tendency to help, this tendency to want to help others, this is a part of our culture. I mean, even the Gandhian philosophy, it was always about trusteeship, donating, compassion, and even in a selfish way, if you want to really have your near and dear one live on longer, you can appeal to them. So if we have this ecosystem of grief counselors, putting them all in place at a personal level, about exactly a year ago, late October last year, my sister, my first cousin, she was all of 40 and she was living in Canada, and a very healthy person, very fit, but as sometimes fate would have it, she developed aneurysm and suddenly died. Now the medical systems there were able to then preserve the body, and 6 recipients have benefited out of all the different organs, including research. So on this note, if we can, and similarly certain structural changes too, like when you have the driving license registration as it is happening in many countries of the world, I'm sure we've talked about this, by default, if it is taken as a yes rather than a default no. So, but it's an educated decision that people make. There are so many things, digital things that we say I agree and go on with it. So if we all collectively work, I think this is certainly doable. I don't want to repeat and take more time, but my request certainly is that since so many people, I think if you count the number of people in this room and the experience that they've all had in different aspects of this whole thing, I think this would be a very, very rich knowledge pool that we have, and it would tremendously benefit all of us, different state governments, but I'm sure all of us collectively, because it's, as has been repeatedly said, it's not just the government, it has to be a collective which works. And in talking of our state, we've had people like Nilesh Mandliwala ji doing some fantastic work. I mean, I'm sure other states would have these champions. I've heard a lot about Mohan Foundation too, because I too, we've been studying the Tamil Nadu model fairly closely to look at all the GOs. I have a bit of an advantage. Originally my mother tongue is Tamil, and so some of the GOs in Tamil were also read by me, and then we got some of them translated to convert it and adapt it locally. So on this note, I think it would be wonderful if this is not a one-off event, and therefore Rajesh ji, at the end of it, if different states can get a bit of hand-holding, mentoring, and I think, sir, you would also have to play a very important role in mentoring, coaching others, because as you said, if somebody has gone up the learning curve, why should others commit the same mistakes or struggle with the same things? So we have an advantage of probably being a little late starters, but that can help us understand things better. So on that note, I'm extremely happy that you're all here. Please share all your insights. And I think these are forums where being frank, open, and knowing what worked, what didn't work, that's very important, rather than just saying things that you may think are sound good and right. But we would be very willing to learn, and I'm extremely thankful that you're all here in big numbers. We also have our own set of champion SIMs and several team members in Gujarat who are doing this. We have an excellent Institute of Kidney Diseases. I'm sure you've all heard of it. And there have been some amazing institution builders. In fact, Dr. H.L. Trivedi, who set up this institute, breathed his last on October 2nd this year. So there are these champions who've built institutions, but we need to do much, much more. As I said, if you compare with Spain, we have to do 40 times of what we are in the state of Gujarat, and which is not difficult. It is fairly simple. It's not rocket science, but it's not easy. It's not that it'll just happen. I think we all have to put our heads together. Simple clarity, where are we headed? And if we work, we can. And we're all determined to do. There's a lot of political will. So I am looking at some very exciting possibilities in the next few months, few years. Thank you.
That was an excellent session on PPP, and I think it's a great beginning. All of us are extremely happy to have so many experts, luminaries in the field of transplant, and all the IAS officers that matter. Thank you so much, Mr. Davidar, for taking the time off. Thank you, Mrs. Jayanti Ravi, for taking the time, and it's really great. We'd like to take a moment to felicitate our experts. May I request Dr. Shroff to please come forward and felicitate Mrs. Jayanti Ravi. May I request Mr. Davidar to please come forward.
Yeah.
Dr. Suresh Shankar.
Suresh, well, thank you.
Thank you. I request Aarti to come. Dr. Rajesh Chandwani. May I request Aarti, the Vice President of NATCO, to please come and felicitate Rajesh. Dr. Dhiren Shah. Aarti, please stay on. Dr. Rakesh Gupta, please, sir. You've come this far. Yes. That's a t-shirt with the organ donation message. I hope you like it. May I request Mrs. Pallavi Kumar to felicitate Dr. Kishore Farke, please. Mr. Amal Sivaji. Mr. Rekhi. I want Mr. Rekhi first. Thank you so much, sir. Mr. Aman Bhaiya. May I request Dr. Rajesh Chandwani to please come. Dr. Somnath Chattopadhyay. Dr. Atul Mule. Mr. Sandeep Kumar. Thank you. Thank you so much for this wonderful session. Are we breaking for tea now? Yes? We'll break for tea. Please come back exactly 10 minutes from now.